Thank you. If you'd like to take a seat, and we'll kick off the debate again with a new panel discussion entitled Which Door to Knock On? If I can ask Marianne Binst to come up to the stage, Valérie Brouchou as well, Yves Deprost, Laurent Zarnitsky, and the debate will be moderated by Elisabeth Hubert. We've got a short video to start. Off we go. In terms of health, even in France, no patient has the same deck of hands. If there is a problem, you don't have the same chance if you're young, rich, and living in a big city, or if you're poor, old, diabetic, and living in a rural area with no medical healthcare services. So some inequalities are obvious, but others are not. When things go wrong, the world is divided into two categories. People who know who to go to, which doctor, which hospital, which clinic, and then there are the others. In some regions, it's better to go and see somebody for a hip rather than somebody else. It's better to consult X rather than Y. When you are in the know, you know these things. But how not to get lost in this jungle? How do you decide? What do you base things on? There are lists of hospitals published in the press, but they're not very complete. What about GPs for complex pathologies? The GP doesn't always know what to do. There are the emergency wards, but there you're going to be waiting for ages. So orienting patients, regulating patients is something that can be done. We actually already know how to do it thanks to the ambulance service. In extreme cases, for example, heart attacks or strokes, we know how to send patients to the right place. Why not be able to do this for pyelonephritis? We should be able to help people to go to the right place. Getting people to go to the right place means we need something that has been taboo up until now, an evaluation that is independent of the medical quality of services carried out by the Ministry of Health. We have the data. Why not cross the bridge? Why not go further? Why not, like in the hotel industry, give 3 stars to a hospital where waiting times and quality are excellent? Why not give a geriatric ward 3 stars if they are good at dealing with old people? Why not have guides to hospitals? Because there are differences, so why not be more transparent about this? Thank you very much. So the film sets the scene. But it's true that given the previous panel discussion and given the conclusion drawn after this panel discussion that showed us a dark future for the medical profession, because I was wondering whether it wouldn't be useful to moderate the panel discussion and and just give you the benefit of a break for 1 hour. But with the 4 people around this table, we're going to nevertheless carry on our discussion. We can perhaps ask a number of questions to begin with. First of all, can I see a doctor? The second, we need to ask whether that doctor, once he or she has been found, well, how do you find that doctor? Having found the doctor, what about their skills? Do they meet my requirements and my health problems? And then the third point that I will suggest already is what kind of support or media should be used to talk about the quality of doctors? What are the right, how can we get the right information? Why should this information just be available to the most comfortable and well-off people in Paris? Why can't we have this information be available to everybody in the country? There are 4 people around this table. They all come from different backgrounds. Each will have their own ideas, therefore. Now, these ideas may not be the same, and so we should have quite an animated discussion. This is what we wanted, in fact. We're going to start with Marianne Binst, who is the CEO of Santé Claire, networking, competition, negotiation. That's what her world is all about. She's involved with a certain number of activities, not just medical activities. So I will let her talk about this subject of information. Who, how, when. Thank you. Yes, that is our job at Santé-Claire, is to send patients to the right people, send customers to the right system, the right health service. It's a very new job. In fact, the company has been around for 10 years. It's new in France. The job is new in France. It consists in setting up agreements with health professionals, quality price agreements for optics, for prostheses, for dental implants, for refractive surgery, or soft medicine, osteopathy, estheticians. So we create networks, and for each new network, we study the economy of the profession, the quality challenges, the problems of the patients, and we negotiate a specifications document with the right kind of quality price relationship. We've got 8,000 people that we need to protect. They access our service via their additional health insurance. So it's important for us to work properly with those patients. And we've got a whole team with experts. We call on outside experts to help us to access information in ophthalmology, for example. We have 2,000 opticians with low prices, 40% lower than normal prices, and a high level of traceability. This is a big problem. It's the same for the dental profession. In implantology, we've got low prices. Half of the implants carried out in our network are of a very high quality, involving high-level professionals. Whereas the average price in France is 2,200 euros, we are offering 800 euros. So we are more than halving the tariff. And then there is monitoring after the operation has been carried out. So as far as doctors are concerned, we don't work with them. We're not allowed to by law, because healthcare networks are not allowed to negotiate anything, whether we're talking about quality or prices, with doctors. And this has created a certain number of strange effects. We have a certain number of stomatologists in the network, and some are involved in the dental area, and that means that they are faced with a paradox. So we help patients via internet as well. We've created the first cancerology, oncology system to help patients see the right doctors. So it's organized by a type of cancer, a type of treatment. So for best survival rates, it's a site that can be that is an open access site. We also have a site on self-medication, the best kind of medications for each symptom with the best quality price ratio in relation to the prices practiced. So it's we have a fairly broad coverage. The main idea is to bring patients information that they don't have access to, and to help things in a very efficient way. But we could go even further if we had great access to information, because each new dossier that we take on board involves an awful lot of work. It's a lot of work trying to get access to information, even though legally we should be able to have access to this information. So there's an awful lot of time wasted. And in some cases, we don't even have access at all, notably concerning freelance GPs. They keep their information to themselves. Thank you, Marianne. I'd just like to ask a question that you may answer later on, not concerning the last points, even if we'll come back to those. But at the end of the day, in the quality price ratio that you mentioned, how can we be sure that at the end of the day, what guides the action of your structure is not the price rather than the quality? And the second thing, is the patient a winner, or is it the additional health insurance company that has more to gain? So these are questions that I would like you to come back to later on. Yves, you are working in the hospital sector. Perhaps you could be part of that network. Is it possible for you to be part of that network? I mentioned the privileged areas of Paris in my introductory speech. Now, you're in the hospital sector in Paris. You worked as an advisor to a minister at one point. What are your ideas in terms of information and how it can be delivered more directly to patients? Thank you, Elisabeth. Yes, there is an awful lot of inequalities, and I'd like to talk to you as a practitioner, as a doctor, and try and be concrete. I'll start with an example. It's 11 o'clock at night. The phone rings. It's a friend who says, I've got this wrong with me, that wrong with me, and it seemed to be a pyelonephritis. It's 11 o'clock in the evening. I wondered what to do. So I phoned the urologist, and I thought to myself, the urologist will solve the problem. But that's where the inequalities are. If the person had been to the emergency ward because the person lived next to a hospital, the person would have waited 6 hours to see an intern and suffered. So that's not big data, it's friend data that we're talking about here. And that brings up something that's important. But I'm just going to go into the detail about two things. First of all, you have to know the right person, whatever the time of day. If there is an emergency, but not a big emergency, but some kind of emergency, there is a minimum waiting time. That's the second point. And this is something that was brought up earlier on when we were talking about big data in the previous discussion. You know, there are different waiting periods depending on the hospital, depending on the clinic. This is something that is being worked on by some clinics, says Elisabeth. Yes, what is the best medical team? What is the best doctor? These are the other questions. So there are two things necessary, if you ask me. The first is that you need some kind of regulation. We have regulation in France that is well done in terms of the emergency services. It's well made up. So if you have a big emergency like a heart attack, any kind of cardiological emergency, strokes, whatever, these are very well taken into account, especially by the emergency ward, by the ambulance service, possibly by the fire brigade. Now, I'm not going to talk about the fire brigade and the ambulance services because there's a bit of a battle there. But anyway, that's not the problem. The problem is relating to the medical disciplines that are not used to working with emergencies. Now, we can talk about infectious diseases. We can talk about dermatology. People don't imagine that dermatology can be an emergency. In fact, there is a 24-hour services in the Île-de-France for dermatological problems. And if I ask most of the people in this room, very few will not know where it is. And it's at Henri Mondor. People don't know about this dermatological emergency ward. And that's why regulation is important. With Pierre Carli, we looked at the ambulance services, and usually anesthesiologists are involved in regulation. They're not involved in the ambulance service because that's where things are very, and it's in the ambulance that things are very difficult. So we need to have some kind of regulation that is more regional, perhaps for the regional health authorities to be in charge of. We've mentioned these already, but we need something that is much more developed according to disciplines that are not disciplines that are used to treating emergencies. And we can come back to collaboration with GPs. And the second thing you mentioned already, Elisabeth, I don't want to talk too long about this because we'll be coming to that, and that is the question of evaluation. This is a major problem. Now, if we don't have the right kind of evaluation, things are not done well. And I'm scandalized that in France, evaluations are carried out by the press, by the media, evaluations of hospitals and clinics, so that, it's not based on scientific methodologies. And it's scandalous to see these lists of hospitals in the press. Authorities should be in charge of these evaluations, perhaps the regional health authorities, perhaps the health ministry. There are drawbacks, of course, relating to these authorities, but they have different objectives from the media's objectives. So, two first speakers with a slightly different point of view. Marianne, through her experience of evaluation and networking, she talked about a private intermediary structure that acts in a regulatory manner. Now, Mr. de Prost has talked about regulation, but with more of a Hegelian point of views. He talks about regional health authorities and their role, and he also talks about the HAS taking a more state-related point of view. Now, let me turn to Valérie Bouchou, who is the president of Doctissimo, and I'm sure she has a third point of view that is slightly different from the first two. So I can see that people don't trust the media, and that's rather sad, but it is important to trust patients. Patients, at the end of the day, we haven't really talked about them very much this morning, apart from to say that they find it difficult to access the right kind of healthcare. We've talked about big data. We don't really include them very well, our patients. And I think that's the real problem in our healthcare system. There's no trust. You know, we all are distrusting of each other. We wonder what they're going to come up with. And it's very difficult to hear what the patient has to say in this context, although the context is changing. And if internet sites have been so successful, it's basically because for the first time, patients are able to express what they have to say. Now, of course, patients don't classify doctors, although they do in the United States, and they're all very happy about this. The patients are very happy with their GPs. If you go and have a look at zogdoc.com, which is a site for making doctor appointments, and you read the comments, you will read what patients say about their doctors. They're amazing. They were so great. But very few bad marks for doctors in the United States. Why don't we want to hear patients? Have we still got this kind of power struggle between the doctor and the patient? I think that things are changing, but things are changing very, very slowly. We realize today, well, in fact, there was a good article in the Quotidien du Médecin that appeared at the beginning of the month that many doctors still refuse to look at applications for following pathologies that their patients use. They don't have time to look at those applications. And yet, when you prescribe medication, when you prescribe a drug, you should be able to prescribe an application at the same time in order to save time, in order to build on efficiency. The treatment would be better taken by the patient, and money would be saved. So everybody has something to gain by listening to patients. So I think we have to put the patient right at the center of the debate. So I was saying there were three different debates. Three different points of view, let's say. They're not entirely different, says the gentleman. Yes, Alain Condier said that the patient should be at the heart of our debate. Yes, but then, of course, it's a bit like GPs, you know, which way do you turn the patient? There are a certain number of concepts and words that we love to use. Do we all put the same thing behind them? I don't know.
Well, here we've actually found one, not for the patient, but if we had to hold 4 or 5 round tables, we're all patients. Laurent is a doctor. He's a GP in addition to that, and he has some varied experience because he's been a doctor not only in the nice places in Paris, but also in Saint-Denis. So he has a very broad idea of what actually goes on, and he can tell us more about what he's heard and tell us about how the doctors are sometimes challenged and perhaps raise our suspicions on the doctors, because we do need to go and see them to make sure they're good. Well, thank you for having invited me. It's a trap, of course. I expected it to be so, but it's very interesting. The debate is interesting, too, because I have a very high idea of my job and what I do. And for the young generation who feel a bit demotivated about being doctors, I think that it's an honor for me to be invited to this colloquium where we talk about non-equality. And for doctors, I think that you've got to understand that the doctor can contribute to getting a patient out of a system that is unequal and guide him around the offer in health insurance and what goes on the internet, the difficulties of the medical environment and the health determinants that generate these unequal situations, and the fact that it is sometimes difficult to have access to healthcare, and a lot of our patients are not covered for the digital side of things. Some even not covered for their healthcare, and before they get into their professional life, or they're switching between two different teaching institutions, we have students too who don't have a basic coverage or any comprehensive health coverage either. So what you've just said about our job does show that we do play a pivotal role in helping people to get through the system. When I talk about assessing GPs, our mean age is quite high. I'm 64, and our colleagues are often suspected of doing non-quality. They've been on the job for 30 years, and people aren't as discontent as that of our doctors. And I'd like to attract your attention to the singularity of the relationship between patient and doctor. We're talking about regulated professions, and this does have something to do with the choice of a psychoanalyst or a notary. And the doctor is somebody who welcomes the patient into the system, and the doctor will send you to a dermatologist. The dermatologist is part of the pathway you take, but doctors are not accredited individually. That's something that some have proposed. But we're in a sort of regulated profession with a very singular relationship between doctor and patient. Sometimes you can't choose the doctor you go to, others you can. But whatever happens, this has to be something that's published. We should be able to know whether you're sending your patient to somebody who's close by or sending to somebody who doesn't isn't approved for normal fees or not. We spend our whole day dealing with patients who come in with serious illnesses. They're not just colds. When I see 20 to 30 patients a day, I avoid 5 people going to the emergency department. And we see some serious diseases, I can tell you. People come with all sorts of information they've printed out on Doctissime or the University Hospital in Rouen, something written in English. I had a patient with a myelloblastoma, and they had taken a look at the nanotechnologies found on internet at Cambridge University. So every day we have to face this sort of thing, not only people who have an unequal access to health care and are seriously ill, but people who inform us and improve our practice as well. Before we go back to the debate, I'd just like to say that this is a generalist who's talking about training. Let me turn to Yves de Prost. I'm talking to the university person, not to the hospital practitioner. Every now and then when you look in the looking glass, don't you say to yourself, well, I haven't done perhaps all I could to train the current generation, the up-and-coming generation of doctors, and that they're still like they were 30 or 50 years ago, and we ought to train them to use the internet, to health economy, and so on and so forth? That wasn't planned for the debate, but well, we've already discussed this issue when you were the moderator of a working group for the Ministry on GPs. And it's quite true that there are things to criticize in the way we've adapted. But in this specific area, it's quite sure that it's the teaching that creates the problem, and it's the universities as well that have to play a different role. They've got a major role to play to make sure that we're not going to really be the doctors of the nurses of the future, as somebody said earlier. Somebody said that they will be the nurses of the future in 30 years, but on the level of training, it's essential to change the system, especially not the basic training, but the lifelong training. Marianne, I concluded from what you said that you were challenging a certain number of people in this room, probably said, oh, well, the assessors have got to be interested to orient things one way or the other. So as assessors of the professionals, what do you do to make quite sure that their practice is not challengeable? And you ended your talk by talking about the fact that you regretted not having access to a certain amount of health data. We talked about that earlier. We talked about the health data that was available to us, the health insurance system data, for example, the PMCIDTH data. What's your standpoint on that? Well, on quality, this is very interesting because as soon as you work on prices, people start saying, well, you're going to decrease the standard or the quality. But the point is that nobody's actually implemented a process to assess their standard, and nothing is transparent for the consumer on quality. So our interest is when we talk to implantologists, for example, that the rejection rate should be as low as possible, and for glasses that they should be happy with their glasses and not want to change them immediately. You've got the expenditure for the complementary fund as well. Very often quality is an ally for them, and they reimburse better for good quality. So there's no real struggle in this respect. In dental practice, for example, that's something that's very specific to us. We work on dental level on inspecting the patient before prosthetic devices are put in, because obviously in many cases the root canal treatment is not done properly beforehand, and that is what ends up by the patient having an abscess. And this is non-quality, and this non-quality item is listed by the scientifics. And there's a reference list from NAHS on this. But it's not always done properly. As soon as we have a new partner dentist, the first thing we ask them to do is to provide the x-rays, and the teams of dental surgeons inspect them. They have some precise inspection points. They even inspect the inspections to make quite sure that the new dentist has been inspected properly, because the idea is that we don't want one to be more severe than the other. So we inspect the inspectors, and we have a 10-year guarantee on all the dental prostheses that are put in, because we've been able to convince the insurers, the policyholders, with figures that when they used the right dentists, their dentures lasted longer. So that's reassuring for the consumer. They say, well, it's quality because it's guaranteed 10 years, because otherwise it's very difficult to provide an argument in favor of quality. And we've also done quite a lot of work on dental prostheses. So it's part of the law in some ways, but it's not always applied. We have to comply with a special tracking system, and that is legally required, but it isn't always done either. And in our network, at any time, we can ask the invoice from the person who manufactured the prosthetic device to make sure that the price complied with the standard rate, because when it's not legal to make cheaper prosthetic device, and when it comes from some rather exotic place, they are invoiced at a lower rate. So when we inspect these devices, we find something like 4% of the prosthetic devices that do come from these exotic countries. There's no in control from the health authorities concerning the metal used either. We told the health authorities that some of the tracking numbers, which were always the same, whatever the process and wherever it came from, were false. And the same laboratory is still putting these false tracking numbers in for imported prosthetic devices. So now, today, we're very concerned with quality. We'll go back to access to data later. I think that's very interesting because you, what you said about the complementary health systems is very interesting. I don't feel concerned by this particular topic, probably because I didn't understand it all. The reimbursement of glasses and teeth, dental care is something that's very important, and it's important for our patients too. We were talking about internet and data. People come and see me, and I listen to them, and I can tell you that I know addresses in Hungary, for example, where people from even the nicer places in Paris go and have their dental treatment because it costs 4 times less. I was against it to start with, but now I can see what goes on, and I can tell you I'm for it. I don't know if anybody's assessed the quality, but they even have dental consultations where they prepare the patient, and they go to Budapest, and there's on the internet there are many sites that promote these dental centers. Should I tell people not to go there? Well, I don't think we're not promoting Hungarian dental sites because we feel that the offer of care is non-visible in France. And we've decided to make it visible to all through a site which is called Mon Docteur. If you need an ophthalmologist tomorrow, then go and take a look. It's if you're just at the till at Carrefour in Épinay-sur-Seine, you might have not have the luck to find this. A non-visible offer of care is what? Well, it's an appointment that the doctor has to cancel in the afternoon, and I invite you to go and take a look and see what it's all about. Well, how do you assess the doctor you recommend? The patients will make the assessment of that doctor afterwards. If I understand what you're saying there, you are not actually relaying primary care, as Laurent said, and you're not advertising anything without it having been assessed, but you're talking about a service. And the doctors register on this site. It's rather like a sort of secretariat. Yes, absolutely. Since some doctors share a secretary, it's the same sort of thing. Yes. And so therefore, you're talking about that type of services. But in the future, you're thinking about having the system assessed by the patients. Yes, by the patients as well, because a patient could perhaps say on the basis of objective criteria that the doctor was running very late or was very unpleasant, that the waiting room was dirty, and that he didn't wash his hands before he did the consultation. There's no reason that the patient shouldn't be able to say that, and they do say it. They say it to their colleagues at work. And this is word of mouth to the power of 10. It's something that's organized. This is what happens on the Doctissimo forum today without assessing the doctors. but all the opinions, and there are 200 a month, which is nothing in terms of the hundreds of thousands of messages we get. But there's a sort of collective intelligence in that. And at the end of the day, the patients don't make very many mistakes when they all do it together, and they correct each other as well. Well, first of all, the fact that we assess the doctors and that the patient's opinion counts, I agree with that. I'm really for it. But medicine is not just that. It can't be reduced to that, because we all know that there are some doctors who aren't very good on the medical aspects, but they receive the patients properly, they smile, and they know how to talk to them, and that's fine. It's all very well. But medically speaking, they're not necessarily that good, because it's not the same thing. You mustn't mix up the different assessments. You've got an assessment of the way you're received, the way the doctor behaves to his patients, and all that's all very well, and it's important, but it's not the most important. The most important is to know what results that doctor gets. For a surgeon, you've got to take a look and see what happens after an operation. And nosocomial infections are important too. We have methodology for that, and it's becoming more and more widely used by the insurance companies and the health insurance funds. But it's not just based on people being interviewed on the sidewalk. Did the doctor smile? What time did you see him, etc.? That's not what we're talking about at all. Yes, but we also need to know about that. Well, you're not all that far from each other in your opinion, but you're not really talking about the same thing. Valérie is talking about a certain number of points concerning the environment, which also have their importance because they're part of the evaluation. We all know that quality is important. We all know doctors that aren't very agreeable with their patients. Through your hospital practice, that's to say before, by the principles of certification the hospital gets from the health system, and through a number of other points that are perhaps could be contested. At the end of the day, between something which is more medical and more public and something which is more liberal in the sense general of the term, Marianne, as you see the health insurance funds who want to improve their margins, do you think that the people who pay could be more efficient than they are by cooperating more with the professionals, using an interface and perhaps other criteria? Well, typically, as I was saying earlier, and I don't see how this concerns the doctors, but it could concern them because there are activities and assessments that are perhaps connected to what the patient feels. And once they're in the network, they can give their opinion. But we also have assessments that have to be made after having access to data through expert systems, defining clear criteria to make the assessment. What we've done for dental care, I'm not saying it's easy, but we could do it for medicine in general. We could send an expert group who know the subject well and define 10 criteria that could be used as a base to assume that the quality was good. But if you have an expert group with a proper working method, then you can quite easily come to a consensus and say, to start with, we've got to be fairly modest, but we could use these 10 points, and if we all see them the same way, that could give you an idea, or at least an assumption of quality or non-quality. But the real issue is quite simple. It's not a financial one, because we do negotiate when we increase the rates to make sure that we have a service of quality and 6:1. And we might say, well, where do we get this information to illustrate these 10 points? Antibiotics should not be prescribed automatically. There are campaigns on TV. But what do you do when you go to the GP to see whether they prescribe antibiotics properly or not? I have a site, and before I register with the GP, which is now compulsory to get reimbursed, I'd like to have information on how many in how many cases he prescribes antibiotics and the number of consultations he does without antibiotics. And of course, the patient's opinion is important as well, but I like to know more about the number of certificates he writes out for people who want sick leave. Sometimes it's hallucinating. The practice is sometimes incredible in terms of sick leave. So I'd like to have some objective criteria. As soon as you're going from one area to another, it's very difficult to get on. But there are the same possibilities in medical, dental, and refractive surgery. The only problem today is whether you have access to them or not.
The example that you took from a general practitioner was perhaps not the best example. Well, not everyone at the same time, please. Now, I will give you the floor. When you're talking about criteria, I think these criteria exist. It's not the complementary insurance companies who have rolled them out. Didn't the state health insurance negotiate with doctors? I have some representatives here. There were some negotiations. And I think these gave rise to additional bonuses for doctors who met the criteria. So, is that the method that you would recommend? Well, you can't go from one excess to the opposite excess. I read in the doctor's daily newspaper yesterday where people were saying we shouldn't go from one message to another message. I think we need to find some kind of happy medium between the ROSP, or RUSP. So can you tell us what that acronym is? It's okay. If you could tell me what so it's actually performance criteria in terms of public health. Let's go back to the two criteria that were mentioned earlier that seemed obvious, which consisted in saying the prescription antibiotic prescription rate and the sick leave certificate rate, which are often linked, actually. Now, the antibiotic prescription rate, I discussed this with the regulator for SOS, for the emergency doctor service. And there was that big campaign saying that antibiotics were not automatic. And actually, there were some problems with children and infants who had meningitis. They had 2 cases of death near Paris because the prescription had been made of amoxicillin. And people said, no, we're not going to take antibiotics. It's not automatic. We're going to wait a little bit. So that campaign can have negative effects, excuse me. And these are real examples, exceptional examples, as Jean-Jacques Rousseau said, to promote his philosophy of life. There are exceptional examples which are completely catastrophic. So I would just like to say that we should be careful. If a doctor is good, he's not going to prescribe antibiotics when they're not needed. And the prescription rate might be lower than another. But just imagine, this is not a good criterion for comparison. It's atrocious. We know what we have to do in the next 15 years. We're not in a situation of unemployment or difficulties that our patients have to deal with. Now, when you're talking about sick leave certificates, obviously these are very important. There are sick leaves. People line up in front of dispensaries and say, please give me a sick leave for 2 weeks. There are people going through if you control a European medical center, you'll see that it's the patient who dictates the sick leave, because the identifier number of the dispensaries, people don't have a number that's an individual number, and we need to discuss this. And there's about 100,000 people who go through these dispensaries and get excessive sick leaves. Now, let's look at breast cancer in my clientele. There are about two new ones per year. And in my clientele, am I a bad doctor because I have 10 breast cancers per year? Do you want to propose this type of healthcare system, this type of assessment? If you want to be really making a dramatic change in terms of access to healthcare, I do not agree with your criteria. Well, so there's no benefit to transparency? Yes. We're going to remain with a completely non-transparent system, and we won't be doing anything then. You're not doing anything. I think I'm the moderator here. Please, we need some quiet. Please, all of you. Now, each of you have 1.5 minutes. Otherwise, my controller's name is Guy Valencien, and he's going to rap on my knuckles if we go beyond the allotted time. So I give you each a 1.5 minutes to say, not that the previous person said something silly, but to say we are today obviously at a time where information exists. The means are multiplying, the media is multiplying. All generations have access to this information, and this will be increasingly the case. How can we ensure that doctors are not excluded from this system? How can we indeed make sure that doctors take ownership of this? How could doctors perhaps be more proactive and make proposals so that they themselves would accept to be controlled? I'm not sure that the certification in certain establishments was something that people were joyous about, and the accreditation of doctors exercising risky specialties now are accredited. Isn't there something that we need to imagine by the medical profession, or using these public health objective criteria? Could we apply them? What do you each think that we should do? What would be your solution? I'll give you each 1.5 minutes. Yves, your solution, please. I want a development of regulation, but that's something else. But that's very important, because assessment is not necessarily regulation. Now, let's go back to assessment. Assessment, for me, is an extremely difficult issue, very serious, and it should be handled by experts. Experts who, first of all, are the medical community, whether in the form of colleges or learned societies or disciplines, or the medical schools at the universities. And I agree, they haven't done the job that they should have been doing in recent years. This is absolutely fundamental for me. But we need to be careful. I am not against the fact that we take into account patients' opinion, but that won't be the most important opinion, that's clear. And don't tell me that because we refuse an assessment performed only concerning patients' questions, we are late in terms of science. After we've just talked about big data, it's another problem. And let us keep a medical expertise above all. Well, I think if we do that, we won't make any progress, because otherwise it would be already done. Often the dynamics come from a stimulation by outside players. Today there's the AFNOR certification for the optical sector. If we hadn't had that certification, we would never have. We really pushed to have this certification, and now opticians collectively are paying for this certification, AFNOR. So I think in every profession there is a complex problem of assessment. Any profession has its complexity in terms of assessment, and other professions have succeeded. As a dietitian or osteopaths, opticians, orthodontists, they all have their specific issues in terms of assessment, and we need to take them into account. We're not going to do the same specifications for everyone, of course, and we can look at other professions, not just in the healthcare sector. So the capacity of an expert group to create references exists in every field. It exists in private medicine as well as in the hospital. So the problem is not to find a reference system. It will evolve. That's normal. But then we need to have access to information which feeds this reference system, and then we need to be able to share it with all of the actors in civil society and, of course, with patients, because they are demanding this. Today, for me, the solution that will make things progress is open data. And this proposed bill of law that's been proposed, they said no information will be available on healthcare professionals. So that we hoped that the black box would be opened up a little bit, and it's been closed again. It's never been opened, and it's going to remain closed. And I think that's really a shame, because I think it would be in doctors' interest as much as in the patient's interest. Except for today, they don't realize that, because it's complicated to change. It's complicated to be stimulated by other actors than those who you're used to. It's not much fun every day. But I think overall, I think it would be in the interest of the profession. I think it would be healthy, very healthy, that the profession be assessed, and that itself, it make these reference system move forward. And without this movement of civil society and open data, the profession won't do it itself. Well, I think civil society is on the march, and that movement is already underway, and it's just Doctissimo exists. It's an individual initiative. These startups will be moving things forward, and they will be moving things in terms of appointments and also giving grades to doctors. So the evolution will come not only from patients but also from civil society. But this has to be accompanied. We have to break open the legal framework that is constraining us today. It's completely inappropriate, and it prevents us completely from changing. Well, we see here how, indeed, we have the patients, and their community can give opinions. We have experts who give expert opinions. And Marianne is saying, I'm ready to integrate all of this in my databases to ensure that this can be used and, of course, and to objectivize quality. So we have information which is produced, generated, which is then analyzed and will be published. And how can the doctor react? So it's going to happen. So what will the doctors do? Because at the end of the roundtable, I'm sure a certain number of people here in the audience say, well, it really looks like the doctors are in a situation that Laurent was describing, where by 2030, they will be losing consideration. That's not what he meant to say, and he didn't want to criticize nurses, but he said doctors will become, and doctors are certainly not technophobes. They're not opposed to assessment. They refer to the referential of best practices for the major pathologies on the HAS, on the National French Health Authority website. We refer to it constantly. We try to follow this, and not under the stimulation of insurance companies who are going to be omnipresent as of 2016, that you're putting in place with the monitoring of data that will be. Well, it's not the insurance companies who are asking for this. But let's be clear for our young colleagues. I think the improvement criteria will be advertising the way we practice in terms of our sectors. We need to be transparent in terms of our different chains and sectors. We, as specific practitioners, even in the hospital, there's a special relationship between the doctor and the patient, and we need to publish this. Depending on people's solvency, we will send them to a specific dermatologist or orthopedist, and when they're on the list of the hit parade in the magazines, people read these rankings for public and the private sector, and I look at the number of patients, and I try to determine how people interpret this. And people say, oh, you sent me to that clinic that's only 72nd in the ranking. People do this every day. These iPhone applications, they use them every day. And the objective is to ensure that they're less and less what we call urgencyism. There's a tension between the offer and the demand. And that person who spoke out during the heat wave in 2003 because he was in the spotlight and he was given money, and you're not going to pay this for 20 years. There are 3 billion euros spent for the emergency ward. We need to regulate the system. If we do our work properly, there wouldn't be anybody in the emergency wards. If the insurance companies and the state would cover the patients who have unequal protection today. Some people have nothing, some people have everything, and the people in the middle are trying to navigate between the two. Today, the solvency of the system, in my opinion, contrary to what is often put forward in the debate, doesn't exist. There are at least 3 levels of solvency, and there's good and bad medicine. So there are at least 6 speeds of medicine in France, and we need to solve this. And I think this is the role of the public authorities, of the national health system, the state insurance system, and those who manage the hospital. When people arrive in the emergency ward, it's a catastrophe. Well, we are running out of time. I'll just say one thing. I'm not sure that I would wait for the public authorities to do something. You can see what's happening today. Maybe that's not the right solution. I think the conclusion of this roundtable is that we could say that indeed it is imperative that doctors really take ownership of this issue if they don't want to just experience it passively. And one other comment, don't forget that there are certain places where people don't even ask themselves whether their doctor is good or not good. Their concern is whether they will be able to find a doctor not too far from their home, which is less than 30 kilometers. Thank you so much for your participation, and that's the end of our roundtable.